Okay, so today's session is on fracture shaft femur, and roughly we have divided it into four parts. The first part is I'm going to cover is about conservative treatment. Then Dr. Shikal Parekh would join and he will speak to you about the elastic nail principles, the technique and complications. And then Sandeep Patwardhan would talk to you about adolescent femur fractures because again, the treatment here is different. And Premal will take you through some interesting cases. And hopefully we will cover all this in next couple of hours or so. So it's going to be an extensive session on shaft femur fractures. So this is the third most common lower extremity fracture, fracture shaft femur. And 1.6% of total pediatric fractures are femur fractures. So not that common, but it's of interest because there are a lot of options and decision making sometimes can be very difficult. Now, I went through history, and this was a model which was found from Egyptian mummies. So there was a adolescent patient with femur shaft fracture, and surrounding the mummy they had wooden sticks. So there was some sort of immobilization planned for fracture shaft femur even in those days, and they followed the principles of maintaining alignment and length. And here you can see that around 2 centimeter overlap was accepted, which is the right thing to do. This patient probably died before the remodeling takes place, and that's why there was mummy. We really don't know the cause of death here. Now, plasters came into vogue in 1851, so end of 18th century. And soon after that, Thomas's splint came into picture, which was popularized in First World War. And the plaster spica, as we do it, it started actually soon after our independence, 1948. And spica cast application and short-term outcomes were first described by Demeron and Thompson in 1959. So, it's almost now, if you say 1960 as a treatment of establishment, it's almost 60 years since people have been using hip spicas for treating shaft femur fractures. So 3 documents I want to share with you as guiding principles for fracture shaft femur in children. So this is a statement from Dr. Still Lynn Stiley from his textbook of pediatric orthopedics. And he mentions that there are multiple methods available for treating fracture shaft femur in children. And you have to choose one. And what are the criteria for choosing the best treatment? One is that it should control alignment and length. Secondly, it should be comfortable for the child. Third, should be convenient for the family, because if the child is admitted for a long time in the hospital, it may be difficult for the family to care for the child. And it also mentions that causes less negative psychological impact possible. And because of these reasons, there is a vogue towards managing fracture shaft femur in children operatively. And very young children also we see being operated, 3, 4, and 5-year-old, which should not be the case. One should not misuse these statements. So for our purposes, these 3 points are important: L, S, and D. So it is not a drug to be high on, but L, S, and D, that stands for length, stability, and deformity. So whatever treatment you choose should maintain length, should give you a stable sort of a fixation, not rigid fixation. Stability should be achieved, and thirdly, should not give rise to deformity, and especially rotational deformity, which are difficult to appreciate. So these are the acceptable angulation. This is from Rockwood Green's book, and you will find out, as far as varus valgus is concerned, up to 2 years, 30 degree of angulation is acceptable. But when you go 11 years to maturity, adolescent patient, only 5 degrees of angulation is acceptable. Up to 2 years, 30 degree of angulation in a sagittal plane is acceptable, which goes to 10 degrees in adolescent. And shortening of up to 2 centimeter can be accepted in a child up to 5 years, which becomes 1 centimeter in child which is nearing maturity. So you can see here that the limit of acceptability for fracture shaft femur drastically change between a child less than 5 years, between 5 years to 10 years, and 10 years plus. And that's why the methods to treat these fractures are different. And these are the weapons in our hand. Yeah, yeah. Ram, you want to say something? Please.
Sir, in the previous slide, the acceptable shortening bit less than the 2 years and between 2 to 5 years. Why the difference is there, sir?
Yeah, because of the actual length of the femur. So if you see the percentage length of the femur and acceptance of shortening, that remains same. The femur shoots up in length after 2 years age, and that's why there is a difference.
Okay.
Okay, but if you see the percentage of length of femur where you will accept shortening, that has not changed. I'll come to these figures later on in my talk. There are some more sort of reviews available, and I'm going to share it with you. Okay, so what options we have for management? One is soft immobilization, which is polycarnase and brace, which we generally do in children less than 6 months. Then hard immobilization, plaster spica, from 6 months to 6 years. Traction followed by spica in unstable fractures up to 6 years age. Intramedullary nails, either elastic nails in younger children less than 10 years, rigid nails in some patients who are adolescents. Plate fixation, again, there are indications for plate fixation, and I think Sandeep will discuss about that. XFIX is not very popular. Somebody mentioned XFIX for compound fractures. XFIX is not very popular for fracture shaft femur because there is very high rate of refractures after XFIX. So if you're doing XFIX for any reason, when you remove the fixator, remember to put a rush nail or a elastic nail so that there is no refracture for that shaft femur fracture. So the guideline, this I have shared with you, the guidelines for managing fracture shaft femur from AOS, they are available now. The only irony of situation is after publishing the guidelines, after a year, they did review of the pediatric orthopedic surgeons, and they found that less than 40% were following these guidelines. So guidelines are not to be just written and read; they are actually meant to be followed. So we'll go with these guidelines and see if our management sort of aligns to the guidelines and what are the exceptions to the guidelines also we will discuss. So first, coming on to neonatal femur fractures. So this is a case, newborn, difficult delivery, and when the child was born, there was shortening of the right femur and angulation. And this is patient, and sort of you are sent a call to have a look at this patient and check, and opine as to what should be done. So anyone unsure, you want to opine on this? If unmute and tell us what would you do for this patient?
Spica, sir.
And meanwhile, yeah, hip spica. All right, excellent. So hip spica is definitely. Is it easy to apply hip spica in a neonate, just newborn child? No, sir. No, sir. So if hip spica is not very easy, there are other options. Say gallows traction. Has anyone used gallows traction? Has anyone seen the apparatus for giving gallows traction? Anyone has among the Premal? Have you seen? Have you used it anytime? Gallows traction. Please unmute yourself.
Yeah, good old days. Yes, I have used it. But it's very tedious. But when I was doing my fellowship at Singapore, they used to very routinely use it. So they had a lot of equipments to make it very comfortable. But then also the population, right, about 2 patients being used.
Okay, and now Rainbow Hospital, do you have that? Have you used it, or do you still stock any gallows traction apparatus?
Don't have.
No. So I'll show you people pictures of what gallows looks like. But I've also not used it for a long time. People can type in the chat box, and let us see if anyone has any other opinions. So Balkan frame. Girish, what is Balkan frame? Please explain to us.
So Balkan frame is used for giving a gallows traction, I guess.
Right. So you've used it, or have you seen it, or it's only picture?
No, sir. I just saw it at the side of the wall, sir. Like never used it. It was just on the side of the wall, sir.
Okay. On the side of the wall. Okay. Any other options? So I'll just show you what are the options available. So this patient was actually treated in a spica cast like this. Now, what are the problems with putting patient in the spica cast? It's very difficult to give spica cast in a very young child. And this child had spica removal. This is an AP X-ray, but that doesn't tell you the story. The issue is the lateral X-ray. If you see the lateral X-ray, when the child was 15-month old, Sushant, what do you see here on the lateral X-ray? Dr. Sushant
Uh,
Srivastava, you just want to unmute? Yeah.
yes, sir. Sir, on the lateral X-ray, sir. So there is a I would say there is a curve, there is a deformity which is being
Yeah.
seen, and
Yes.
also, sir, it I would call it as a procurvatum deformity to be.
Yeah. So almost 60, 70-degree deformity.
Yes, sir.
I really don't know whether this will remodel. Of course,
Yes, sir.
there are chances that most of it would remodel.
Yes,
So
sir.
I had a child, which was 3-year-old. I remember many years back. That girl is now 20-year-old. When she was 3-year-old, she had a fracture shaft femur, and she ended up with such a deformity. And took her X-ray at 18 years age. And at 18 years also, there was 40-degree deformity. Fortunately, she doesn't have any symptom.
Okay, sir.
She's a Bharatanatyam dancer and a professional level dancer. And when you see her dance, you can't even make out that there is any problem. But if that girl ever in future requires a hip replacement or a femur nailing, that curve is going to cause a lot of problem, and it's not desirable to have that deformity.
Okay,
So
sir.
not all of this deformity resolves. So this child otherwise is doing well. The shortening will correct, and sort of bow has come down. But even at a longer follow-up, the deformity is partially corrected, not fully corrected. And we are observing and seeing, and this can be avoided. And
Yes,
how do you avoid this? This is a second child, a second case where you have a similar deformity. And this deformity occurs because of pull of psoas.
yes, sir.
Naturally, also psoas is very active in a neonate. See, neonate, the hip is never straight.
Hmm.
Knees are also not straight. They will always have knee and hip in 30 to 40-degree flexion
Section. Yes, sir.
because psoas is very, very, very active.
Yes,
And
sir.
that is what pulls the proximal fragment in too much of flexion. And the way to correct this is to get distal fragment also in flexion. And this can be done. One is by this gallows traction. This is a photograph I have from my residency. And you can see that with the crepe bandage, we have applied gallows traction. And this is to be put on a frame, Balkan's frame. And then and then you really need to watch for circulation because some of these children can have a vascular issue. Some of the children, because of so much of hip flexion, persistently can also develop femoral palsy. And the child has to be admitted in the hospital under observation of a doctor. So
Okay, yes.
that's why this is not a very convenient method. So we replace this with what is known as Pollick's harness. Pollick harness, which is used to treat DDH, can also be used to treat fracture shaft femur. So this is one of the pictures of a child where we have treated fracture shaft femur in a Pollick harness. So it ticks all the boxes. It's very convenient. It is cheap, available off the counter, allows you to clean the skin so that there'll be no skin rashes, and it maintains hip in flexion and prevents a deformity. Now, the only problem is because it's a soft brace, it's not a hard brace. Whenever you treat the child with polycarbonate, there is irritability for 2 to 3 days till the time soft callus. And what I found the solution for that is have a small cardboard and attach that cardboard to the patient's thigh and put a crepe bandage over it. So that will reduce the amount of irritability in that child. Or put a pillow on side of the thigh or a rolled sheet on side of the thigh. That would decrease the movement in the femur and reduce the irritability of the child. So that's how we treat a neonatal femur fracture. Typically, this is how callus will be seen as early as 10 days. You will see profuse callus formation, and you will see that there is some amount of shortening, but over a period of time, you will see that it completely remodels and the child will do well. So that's the choice of treatment for children with fracture shaft femur in age group 0 to 6 years. After 6 years, the psoas hyperactivity goes away. The child cannot be managed well in Pollick harness, and that's why then the role of spica comes into picture. Now, there are some exceptions to this rule. Now, this is a neonate with bilateral femur fracture, but this patient has arthrogryposis and has bilateral knee extension contracture, bilateral CDK, or knee extension contracture. And actually, you cannot place this child in polyc harness because the knee cannot be flexed. So that's a sort of a difficulty in applying polyc harness, and this can be treated with simple, cardboard slabs or plaster slabs to immobilize and and support it on a pillow so that the hip goes in little flexion. So we have to modify the treatment. Yeah, Sushant, you want to ask something, please?
Sir, I wanted to ask you one thing, sir. There was something which we had just read theoretically from Tagdian, that was fracture pillow. So is it going to help us in a shaft of femur fracture, sir? That was read
Yeah,
in
yeah.
DH. Could we
Yeah.
use something like
So,
that?
so it can be used. So anything which maintains hip in flexion
Okay, sir.
can be used. The only problem is French pillows has too much of abduction.
Yes, sir.
Okay, so it may be a little inconvenient, but it can be used, and we have used
If I
just
can add,
hip splint.
your
Yeah,
French
Premal, please.
pillow will, abut very close to your fracture site. While Pavlik
Yes.
harness will go on the leg, it does not have anything on the thigh.
Yes.
So you can, for a position you can use it, but it's not a very comfortable way of doing it. Pavlik harness is
Yes.
much comfortable.
Yeah, that was my doubt, because this was made. We had seen the photograph and the sanitation thing and everything for the patient, for the kid to pass tools and everything. I thought it would be a little bit cumbersome, so that was the doubt I had.
So, Karan, can you go to the first slide of that literature you had quoted? Yes.
One?
So if you look at this, I have also come to after reviewing my cases, that whenever you apply Pavlik harness, you generally get a valgus deformity at the fracture site.
Right.
It stays there in almost all patients.
So you can see,
But there is always a valgus deformity in patients treated with Pavlik harness.
yes, but it remodels over a period of time.
It does.
You can see that this patient, in spite of applying polyc harness, has some degree of flexion. So most of it will remodel. Yeah. So there are again one more contraindication to, or difficulty in using polyc harness treatment is when polyc harness is not available. So it is possible. In Bombay also sometimes we had to order, and it used to take 2 to 3 days. Nowadays, of course, it's available on Amazon. So if you go to Amazon, by chest diameter or child's length, you can have polyc harness available. I think Flamingo is the company which markets it, and you can have it delivered in a couple of days. But there were days when we didn't have polyc harness available, or there are places where people send us x-rays. Dr. Taral, what should we do? And I said polyc harness. He said it's not available. There are simple things possible. A few of the things which are possible, you can strap the thigh to the abdomen. People have done that. A very simple thing is to apply above knee slab with knee flexion. So when you give above knee slab with knee flexion, automatically hip also goes in flexion. It is just to position the leg. And there are various ways you can achieve the same result by using your own innovations. So feel free to innovate, and if you think of a bright idea, please let us know. We will also use it.
Taral, let me share you one funny bright idea we have a few Pavlik harness ready. So what we do is that we keep it ready and take some deposit with the patient. After 2 weeks, 3 weeks, you don't need it. So you return that deposit so that, Pavlik harness is kept well and it can be reused again in a second case. So this, it has helped us, you can use one for at least 1 year, 2 years, depending on your frequency.
Right. Good. So I would come across so many of them, but I think it's a good idea to keep a set of Pavlik harness ready with you, which you can use for fracture femur or DDH, as the case may be. Okay, so let's go to any questions or comments by Anybody from the audience in this age group, up to 6 months? Any difficulties you all have faced? Or,
Sir,
yeah, please. Yeah,
yes, sir. Sir, a small question. Sir.
yeah, please.
Is there a possibility of dislocating the hip while we are applying a cast spike?
It is possible. Is it possible? No. Please repeat your question.
Yeah, I'm asking, have you ever seen any dislocation? I mean, during spica application or after spica
No,
application? Maybe.
hip dislocation. No. You cannot cause a hip dislocation while
Yeah,
treating
because
fracture
just
shaft femur.
1 week ago, somebody has we've got a entire case sheet from one of the institutes, district headquarters institutes. Sir, they have mentioned. So I was not sure. Just asked.
So one of the possibility
Sir.
is that child may be having arthrogryposis and a stiff hip which is dislocated, and during birth must have got a fracture shaft femur because of the stiffness. That is a possibility.
Okay.
Probably that can explain fracture shaft femur and hip dislocation.
Okay, maybe.
Yeah. So this is a possibility. Yeah. Okay. So let's go to little older children, 6 months to 6 years. Yeah, please. Yeah, ask.
Sir, you told it's just 15 mm that is acceptable shortening in the age group below the 2 years, sir. If the shortening is more than 1.5 centimeters in this age group, what should we do, sir?
It won't. I will not do anything. I'll just let it be, and it will remodel. Yeah. Okay. Because the muscle forces will not allow more than that, because these are not very high energy trauma. These are birth traumas most of the time, or the child will fall from a cot and get a fracture shaft. So the amount of soft tissue disruption is never so much. If it's really bothering, I've really not come across such a case. But if it's really bothering, then I will give a traction, box traction. Let length be taken care of, and then apply a spica after a week or so once the callus forms. Okay, so there are simpler solutions, and if case demands, then I would do that. So principles are important. So this is a 4-year-old child with fracture femur, little comminution, and it's a long spiral. So let's start with Ram. What would you do for this patient? How will you manage this? And rest of you can type in the chat box as to what would be your preferred management. Yes.
As this is communicated, sir, and it's oblique fragment. Sir,
almost spiral.
So spiral with oblique one, there is a chance of shortening. So in between, if I want, if I'll check after applying Holic harness, this hip spike, sir. If I'm satisfied, I will continue.
Hip spike. So you meant to say immediate hip spica. So would you do this under anesthesia, or I think Girish also is mentioned? Yeah, under anesthesia or spica. Has anyone given spica to a baby without anesthesia for fracture?
No, sir.
You need some sedation or anesthesia.
Yes, sir. Sir, if I can just add.
Right.
Sir, Taral, sir.
Yeah. I'm listening. Yeah, please.
Yeah, sir. These type of cases actually, what I'm doing is I'm just both the legs. I'm applying skin traction.
Right.
So and then after that I'm converting it to cast. But few of my cases actually I couldn't achieve the length also. Maybe they didn't mean to, because only for 2 days I keep them in hospital and then send them back to the home.
Right. So it's a problem. Yeah. So maintaining length is not that easy. Secondly, when you're applying the spica, again, the one more issue is how to take X-ray. In a small child, it's not very easy to take even X-rays under C-arm. With hip, the position of hip is say 40-degree flexion and then abduction. It's very difficult to take AP and lateral. So I think you have to go by clinical judgments, give traction, and then give immediate hip spica. So this patient, I'll show you what was done on that one. Okay, so you can see that this patient was managed in traction, Thomas's splint. Yeah. And traction looks good on day 1. And if you see, And when the patient comes back at 3 weeks, the traction has become loose. You lost the reduction. There is an angulation, and varus
Same
angulation.
deformities, I think, abduction in the
Yeah,
patient.
and yeah, so AP looks okay, good callus formation. So at 2 months, you have this massive angulation of 40 degrees, and over a period of time, it remodels. It's not that it doesn't remodel, but still you are left with some degree of angulation, which remains for a long time. And in a very thin child, this may be palpable sometime. In a chubby child, this is not even palpable, but length almost always will restore. Okay, this is another child, 3-year-old with fracture shaft femur again, and you can see that amount of overlap is around 2 centimeters. And in this patient, it was treated by a brief traction followed by spike. And you can see the spica has been given in almost 70 to 80 degree of hip flexion and actually has resulted in recurvature. And then we had to do wedging in this child to restore this angulation. So there are various ways to give hip spica, and Sandeep has already shared the video, and I hope those who have not had a look at this video can have a look at that. But we've always there are people who say 90-90 spica because it gives better control, and uh, uh, and it allows the child to sit. But I have learned from Sheetal. Sheetal has joined here, and Sheetal, showed us this picture, and he told us that if you apply a spica in 1990, after applying a below knee plaster and using that for traction, there is high rate of compartment syndrome. And there is a paper by Scott Mubarak from San Diego depicting that. They had a series of patients who got a compartment syndrome. So, what I prefer to do is give plaster in lesser degree of uh, flexion. Sheetal, you are if you are live, what position of hip spica do you prefer in children? If you can unmute yourself and tell us.
Yeah, can you hear me?
Yes, yes.
Yeah, so most of the time, we would give it in a kind of a comfortable position, not a 90 position, but you can say it's like 45, in between 45 and 60 degrees of hip flexion to match the knee flexion as well. But if the fracture is more proximal, like for subtroch fractures, since the proximal fragment is in more flexion and abduction, then you may have to just match the distal fragments. You may want to flex it a little bit more and abduct it more if the fracture is more proximal.
Right. Thanks. So one more question is, how do you give a hip spica? And then people have spica tables, but if you are in a place where spica table is not available, I tend to use a small arm board, which Sandeep also uses for supracondylar fractures. So small arm board which is put under the patient's back, and then you use that as a support and get patient out of the table and give a spica. So one more thing, what we were, discussing, Sheetal, I have not found it very easy to take AP and lateral X-ray in a very small child. So how do you manage that? Do you go with clinical improvement, or you are able to get AP, but lateral becomes very difficult in a small child to take? Oblique you can manage. Maybe.
Yeah, so you're correct. So there are a few things. One is that the newer tables are carbon fiber tables, which allow for fluoroscopy through the table. So that's one thing. The previous tables were, steel, and there was always obstruction to a fluoroscopic view. But the newer tables are very nice.
Right.
The other thing is we have transitioned now to single leg spica most of the time. If the fracture is like mid shaft or distal to it, then you're using a single leg spica. In which case, your other leg you can just extend it, and then you will be able to get it. Even if you're doing a 1.5 spica or maybe a 2-leg spica, we usually give the spica first on the involved side. And so you'll be able to take an X-ray. And then once you're happy with that, then you can extend it to the other leg. So that way you can get the image that you need in a cross-table lateral position without changing anything. And the more important thing, as you pointed out, is the mold is what you're checking, is to make sure that you have a good mold to put the fracture in valgus.
Yeah, so this is what was recommended by Stiley, but we go with actually 40-45 degree flexion, and more proximal fractures. You can go with more flexion, but there is more chance that I will operate a more proximal fracture because they tend to be unstable even in spica. So this patient healed well. There was a shortening of 2 centimeters, but over a period of time he remodeled. So this translation corrected, and you can see that the angulation in both the planes, sagittal and frontal plane, corrected, and his limb length discrepancy also corrected over a period of time. So so not much has been written nowadays about conservative management of shaft femur fracture, but this is a very good systematic review which has come up recently in Journal of Children's Orthopaedics, and I want to share this with you. And some important points here about what people were mentioning. Acceptable femoral shortening. This is a review of almost 60 patients, and they say that children younger than 10 years, around 2 centimeter of shortening can be accepted, but as you go towards puberty beyond 10 years, around a centimeter of shortening can be accepted, not more than that. And that's why people tend to convert to more rigid implants or length stable implants. Now in frontal plane, acceptable varus valgus changes from 16 degrees for a child under 2 years to 6 degrees for adolescents. But sagittal angulations are better tolerated. So that's what this paper says. So this is borderline patient, 6-year-old. So it's neither less than 6 years or not more than 6 years. And this patient was initially treated in a setup in a hospital. 6-year-old child with this kind of fracture. Yeah, please unmute yourself. Sheetal, I'm asking. Are you able to hear?
Sorry.
Yeah, so 6-year-old child. So, it's a borderline case, So what would you manage? Average Indian built patient with this kind of fracture.
Yeah, so, in the past, there has been an option of using traction and then putting a delayed spica for a lot of these patients. Here in the US, we have not, maybe because of the situation, like, we don't want hospital to be filled with a lot of patients, and we have a good turnaround. So we like to put early spica, but, if you put someone in a traction like this for a while, and then put a delayed spica, that probably is acceptable. If this case was here, this would have undergone elastic nailing at our hospital. It's going younger and younger, because of issues with skin issues as well as family issues. Family, want to stay away from spica. So those spicas have improved lately. We have now, even have waterproof spica casts. So the spicas have improved as well. But beyond 5 years and even a little bit younger, we have gone to elastic nailing. But it would not be a wrong answer if it's an average or a small build child, and you treat them with a spica. That would be acceptable. It depends on where your practice is, what resources you have, how the families are. So you have to individualize your treatment a little bit. All these criteria are set, like 5 years to 11 years and weight and everything, but still need to look at all the other circumstances.
So even I would have treated this with elastic nail. If the patient had come to me on day 1, I saw the patient after 2 weeks, and in Thomas's splint, by the time fracture had already become gummy, and it's not easy then, even at 2 weeks, even if you want to do a nailing with a lot of callus on. So we just converted the Thomas's splint into a single leg spica, and that was sort of first time I applied it after reading Jack Flynn's article and his video on Posna's site, and this patient did well. So those of you interested, there's an entire video of walking spica cast application on Posna Academy, and you can go and check. So that's what I checked and did. But after that, sort of younger children now, that has been sort of practice that those who we do put in spica on day one, but those which are length stable fracture go for single leg spica on first day, and length unstable fracture would have a short period of traction followed by a single leg spica. So there are some indications for operating even in younger children. So this was a bilateral fracture shaft femur, road traffic accident, and child also had head injury. And it becomes very difficult to manage such patients in a spica cast. So this patient, we did a bilateral elastic nailing. It's not the ideal indication, also not done in the most ideal manner, but under the circumstances, this was the best we could do. And eventually that child healed well with managing, length, stability, and deformity, all of that. And that's at the age of 16 years. The patient had just come for some other issue, and we could get a scanogram to just check on his lens, and we can see that he's maintained very well. So I'll just share one last patient as to what are the issues sometimes with extending conservative treatment to an older child. So 7.5-year-old child was managed with a hip spica, comminuted fracture with a butterfly, and he landed up with shortening and angulation. You can see on serial x-rays there is angulation and shortening, but the most important issue here was the rotational problem. And you can see that there is excessive internal rotation, which presented as a very difficult gait pattern for this child. And though we waited for remodeling, rotational deformity is something which does not remodel. And if it's uncomfortable, you need to correct it. And this child, after 2.5 years of the fracture, we decided to correct it. And this was done by doing a osteotomy, putting an external fixator, linear external fixator, doing an acute correction of rotation and angulation, and then doing lengthening with a monolateral IFICS over a rush rod. And fortunately, over a period of time, we could get his fracture to be lengthened, aligned, and him to be walking normally again. And we removed fixator after 3.5 months of the surgery. So these were, sort of a few cases and some thought processes on conservative management of children with fracture shaft femur up till 6 years. Any questions from audience? Any comments, questions, queries in managing children till 6 years age? You can unmute and ask, or put it in the chat box.
Tarun, I had, the patient, you can hear me?
Yes.
Yeah, the patient before the last patient where, road traffic accident, bilateral femur fractures, 4-year-old that you elastic nailed.
Right.
So that's a great indication to do it in younger patient. Of course, the other indications, if there are skin issues and you can't put a spica on, then, we have had patients that we had to convert early on because it was difficult to manage with, some infection, skin infection around the butt. So, but the other side is also true. So say, for example, you have a 6 or a 7-year-old who is, has multi-trauma, but is unstable and cannot undergo surgery. And we have had few patients who were, either comatose or, significant morbidity from other injuries. You can just put them in a traction to maintain length. And some of them, would, if they can't undergo surgery for like 2-3 weeks, it is already glued. You might just have to put a long leg, cast on later on to support it. So the other side is also true that you can treat, depending on, we have to treat all patients as a whole, not just a femur fracture. So if they cannot undergo surgery, traction is the next best thing, because you don't want to put them in a spica or a cast because of pressure source and you can't, see the skin. So those serious patients, just a box traction would be sufficient to maintain length, and that's about it. You can check everything. So
one question from the audience is that can we use skeletal traction in this case? Has anyone, or a pin?
You have to be careful about the physis. There have been a lot of cases of having issues with pin track infection, physeal injuries with skeletal traction. You can use it, but box traction is good enough. These patients, if you're not going to be operating, they are kind of a little bit relaxed. Unless you think that there is significant shortening, it could be used. I don't like to use it just because of all the issues with it. Later on, if you want to put a nail through, then you're concerned about pin track infection and all those things. So, and physeal injuries as well. So I try to avoid skeletal traction, just use skin traction. But it's, if whatever resources you have, it's not a wrong answer. It's just not very favorable. And your last patient was very interesting. The thing is, how can you avoid that? How can you avoid shortening, malrotation? And that requires your rapport with the family as well. All these are, like high maintenance. Even if you put a spica on, you need to see the patient back, 1 and 2 weeks, just to make sure they don't have shortening or issues. Because early on, you can address it. Once the fracture starts to heal, it's very difficult to then change things. So you need to look at the acceptable criteria, and you need to make sure that when you check the patient in follow-up, that they're within that acceptable criteria. Like up to 2 centimeter shortenings is okay, but if you have 3 or 4, then you need to change your treatment.
Absolutely, and most of the time things go wrong between first and second week. Yes, Premal, please.
I think there is somebody who meant that give a skeletal traction and incorporate in the spica. I think Sheetal, if you remember, we used to do in our residency days, pass an upper tibial pin and incorporate that in spica, so gives a little added lens stability. But I don't think have done for a long time now.
Right. So for putting a skeletal traction in children, anyway, you need anesthesia. And the total length of time you spend on giving anesthesia and then giving spica and then giving a skeletal traction pin, I think you can do an elastic nail in the same time. Sheetal, you had any comments? Yeah, please.
No, I'm good. I was just going to say that, a lot of things are correct. It's just that we have moved on just because of, some of them are social issues. Some of them, of course, pin track and, physeal injury issues. But a lot of it is caregivers and families. We want to make sure that they don't have to take too much time off, from their work, that the patient is at home, the patient is, socially, it should be an acceptable treatment nowadays. So that is where the elastic nail has been very favorable for a little bit older patients.
In southern India, a popular method, I have also seen as residents being used at some of the centers in South India, was the external fixator. They used to put external fixator for femur shaft fracture, and I think over a period of time, people realize that it has a high rate of refractures somehow. It gives you length, it gives you rotational stability, but the main problem was refracture, and I think the people have stopped doing it now. Unless it's a bad compound fracture with a lot of friction burns, external fixator as a management option is very low on the priority list. The one question from the audience is 6-year-old child with proximal femur fracture with almost 2-inch shortening or overlap. So I would definitely treat this with surgery, and 6-year-old child, I think you can still manage with elastic nailing. What would you do, Sheetal? Plate or nails? 6-year-old child with proximal femur fracture. No, you're muted. Sheetal, we can't hear you. Can't hear you.
Okay. So yeah, I would nail it. I find nailing to be a better option than plating, but that is more, your experience, training, and what the institution does. If you are very good at plating and you feel that you have more control and and you will be able to treat it with minimal opening plating, then I think the thing is you don't want to open up the fractured site and do a traditional plating. It would just delay healing and create more issues with wound healing, infection, all those things. But if you can slide a plate and put 2 screws above and below and just maintain it. It's a good choice. A lot of people here also do it. We are there are nailers and platers, and we are nailers, so we like to nail everything, and we extend the indications of nailing, even beyond what is acceptable. Like I would nail a 13 or 14-year-old with elastic nails, and even a heavier patient than 50 kilograms. So plating is not a wrong option if you are really good at it. Just, you probably need to know all the different ways of treating it, but you need to be really good at least one of them, where you treat majority of them the same way. And then you need to have, this backup options. Like if you are doing nailing and then you find yourself in trouble, you should be able to plate it. So you need to know all your options, but stick to at least one method that you can reliably fix most of your fractures.
Okay, so now we have additional information that fracture is 1 month old. So in that case, I think whoever is putting, I would open. It will require open reduction, and if I'm doing that, then plating may be an option. 2-inch shortening in 6-year-old child, you will not, wait. You will go and rectify that. So with that, I think Sheetal, I want to invite you for the next session on elastic nailing principles and the practice, the technique, and complications, all covered in one.
Okay. Can you hear me?
Yes, you are. Please share your screen.
Okay. Yeah, I'm trying to share. Can you see my screen?
Yeah, it's come. Yeah, we can start. Go full screen and that should be fine.
Okay. So we're going to talk about elastic nails.
Sheetal, your voice is getting muffled somehow.
Okay, can you hear me now? Can you hear me?
Yeah, this is better. Yeah, perfect.
Okay. So, we are going to talk about the elastic nails for the next 30 minutes. I'll try to make it a little bit quick because, and if you think it's going beyond the time, then just, let me know. So elastic nails is known as by different names: Nancy nails, elastic stable intramedullary system, or flexible systems. And it's indicated for patients between age 5 and 11, weight less than 50 kilograms, location mid-shaft. And then the extended indications is what we use for is even if it's a length unstable fracture, proximal, that means substroke or distal fractures, in kids who are less than 5 or more than 11 years of age, and even those who are more than 50 kilograms. So one thing is when you're doing nailing for extended indications, then you need some supplementary, not fixation, but at least immobilization or some form of follow-up to make sure that you don't end up with issues. So if you are going to extend the indications, you need to have a strict follow-up on this patient. So as far as pre-op planning, you need to look at the amount of shortening, make sure that you have muscle relaxation. You need to speak with that anesthetist. Some of these patients are better off on a fracture table. I usually have been doing this on a regular table because in kids it's not very difficult to get length, and we have enough help. We have at least 2 or 3 residents or fellows, so I prefer to do it on a regular table, like a Jackson table. But if you are by yourself or you have less assistance, then doing it on a fracture table probably is a good idea. You want to look at the size of the canal, and each nail is 40% of the canal size. So the 2 nails would occupy 80%. Now, some of the recent studies have shown that this is one of the most important factors, that when they looked at malunion, they found that it was not because of a length unstable fracture or the material of the nail, but it was because of us undersized nails. So it's important to make sure that you calculate the canal size, and each nail is 40% of the canal size. So here are the different nails that are available. From 2 to 4. We have in both titanium and stainless steel. I prefer stainless steel for the femur fractures, especially in heavier patients, but there are downsides of using stainless steel as well. As far as surface landmarks, you look at the patella, and then one finger breadth above the patella is your entry point, typically in the metaphysis or at the metaphyseal diaphyseal junction. And this is the fracture. This is a Jackson table that I've used for my patients, and draw the superior border of the patella. I'll just make a mark there, and that is typically the insertion point for the nail. So you want to check before you make your incision with the fluoro. Once you are okay with the point, then you can make an incision distal to your entry point. And typically a finger breadth below the superior pole of the patella is your physis. So you can check and you can mark your physis so you can see that you are above the level of the physis. You can also do some planning intra-op. There is a ruler that you can use to see what size nail you should be using. But most of this is done on pre-op planning on your x-rays. Once you make your incision, you can go straight down to the bone. You don't need to see anything here. It could be percutaneous insertion. The reason to have an incision is to make sure you don't have skin issues when you're putting the nail. Otherwise, you would bruise the skin. I use a short awl. There are short and long awls. There are straight and curved awls. I use a straight short awl just so that I can have a little bit better control over the awl. It may look like this is a little bit proximal entry point, but I think it's because the X-ray is a little bit stretched. And once I come, perpendicular to the fracture, make a starting point, and then get in line with the leg to make an oblique hole, and then I rotate like this to expand or enlarge the hole a bit. And you can check under fluoro to make sure that you like the entry point here. The other option is to use a drill. You can use a drill with a drill guide. On the medial side, you need to be careful not to plunge posteriorly. Your vessels are there, so you need to be careful about it. It's better to aim the awl a little bit anterior so that even if you plunge anteriorly and not posteriorly. If I've got two residents, I'll have the senior resident take the medial entry point, or the fellow take the medial entry point, and the junior resident takes the lateral entry point. So just be careful. Your medial entry is a little bit, you have to be aware of the issues with it. You bend the nail, you can use freehand bending like this, or you can bend it using an instrument, which is this is the instrument to bend the nail. And most of the mid-shaft fracture, you just need a gentle curve. If your fractures are proximal or distal, then you want to create a bend where the apex is at the fracture site. This is showing the original. This is an original video from the Metazo technique where they do it on a fracture table, and they say that you don't want to use the mallet too much. You can insert it with your hand, and if you're not able to make any progress, then of course you can gently tap the nail to get in. Now, if you insert the nail up to the fracture site, I typically would like to take entry for both the nails and reach the fracture site first, so that when I reduce the fracture, I will advance the nail, which I think might be easier to put in. So if the nail violates the inner cortex, it's out of the canal. So if you see something like this where it's touching it, you don't even need to look at the lateral view to confirm whether it's in or out. It is out. So you can just withdraw the nail, rotate the nail, and then reinsert it, holding the reduction. I try to pass the nail just in one view, just in an AP view first. If I can't get it, then I would check the lateral view. Typically, the proximal fragment is anterior, so I'll have someone push from anterior to posterior for the proximal fragment, and just look at the AP and try to insert the nail that way. And as I said, if I don't get it in 2 or 3 tries, then I would look at the lateral view. Most common displacement is anterior displacement of the fracture fragment, so you can rotate the nail so that the tip points anteriorly. Other important thing is don't keep on rotating the nail too far. So the maximum you want to rotate the nail is 180 degrees. If you want to go back, you have to do it in a counterclockwise manner. That means don't keep on twisting the nail, because if you twist the nail and it's corkscrewing around the other nail, then it's not an effective nail. So you just want to rotate it up to 180 degrees. If you have to go the other way, you come back to your 0 position and then go the other way. Just don't keep on spinning the nail. There are tips to pass the nail through the fracture site. Here is the fracture reduction tool, which you can just make sure it fits the size of the thigh of the patient. So you can just build it on the table, and then you can use that to reduce the fracture. The good thing, again, this is radiolucent, so you'll be able to see the fracture with the tool in position. So this fracture reduction tool is very helpful to reduce the fracture. The other tips to pass through the fracture site, you can use an instrument. Here we are using a mallet to push the fracture in reduction. You can sometimes, if the fracture is sagging, you can put something, maybe a stack of towels, or maybe something to hold the fracture reduced while you pass the nail. And I have not found this to be very useful in the Metazo technique. They describe using the nail as joystick, but it's kind of difficult to do that. Once you pass the fracture site, then this is the ideal configuration where the nail is crossing the other nail at 2 points. One is proximal and one is distal at the fracture site, but you need to have maximum spread of the nail at the fracture site for that to be effective. If nail doesn't advance, then you can withdraw, rotate, and reinsert. You can remove the nail, you can bend the tip, and you can reinsert. And if you really think that it's jamming the canal, then you can downsize the nail. So this is just bending the nail a little bit more because the nail was not getting past, especially the tip. You can bend it a little bit more if you're having trouble getting to the proximal site. And here is bending the tip of the nail. And that would allow the nails to then pass. You can change the curvature a little bit to help you. We hardly ever have to open these fractures. We do have to open some forearm fractures. Sometimes, tibia fractures, I would recommend that you try to avoid opening it, because it does then increase your healing time and maybe lead to a non-union as well, especially on the ulna. But for the femur fractures, I've not had to open a femur fracture for a long time. The first nail to be attempted to cross the fracture site should be the easier nail. Advance the first nail across the fracture only enough to ensure reduction. That means don't put one nail all the way through, otherwise it's going to be difficult to manipulate the other nail. Just cross the fracture site, maybe about 5 to 10 centimeters, and then put the other nail. So you can still wiggle the fracture and get the other nail. But if you pass one nail all the way up, it might be a little bit difficult to pass a second nail. So same with radius and ulna. Once you do the radius nail, don't put the radius nail across all the way through the fracture. Just pass the fracture site and stop, so that you can then manipulate the ulnar nail. So some of the tips to make sure that you can get both nails through. And never rotate the nail more than 180 degrees. You need to have spread proximally, like seen here, and then you can cut the pins with the screw cutter at the level of the distal physis. You then tamp the nail to its final position. These are the impactors to push the nail across. And you can see how much the nail is protruding out from your entry site. Usually about 1 centimeter is good enough, so you can remove the nails later on. You also want to make sure that there is no distraction at the fracture site. So we'll frequently check it. If there is some distraction, you can bend the knee and you can thump on the knee joint to decrease the distraction or make sure the fracture is impacted. I use an immobilizer. Sometimes you would use a cast if the fracture is really unstable, if the kid is young, very young, but immobilizer is good enough. And weight bearing depends on the fracture geometry. If the fracture is a transverse fracture and the nailing, you're happy with the stability, you can allow them to bear some weight early on. I'll show you some of the examples here for a comminuted fracture, what you can do to help negotiate your nails through. This is an 8-year-old girl who jumped off her bed to a chair and fell. And this is the fluoro, and I'll run the fluoro shots so you'll see the struggle that we have while we are doing the case. So we have there is a lateral-sided butterfly fragment. We have inserted both nails up to the fracture site, and we are advancing the medial nail because the butterfly fragment is lateral. You want to insert the medial nail first, so you don't, start to separate the butterfly fragment. So here we are inserting the medial nail. It goes all the way up there. Then we are inserting the lateral nail. As you can see, when we're inserting the lateral nail, it's pushing the butterfly fragment. So you want to try and rotate the nail 180 degrees so that it's pointing medial, like here, and then you can gradually advance the nail. But you can see that there is a little bit of a struggle getting it across. But once it is through, then you rotate the nail back into its position, and then you can put it in the final position where it's in the neck. The medial one is in the neck, and this is the final construct. And so with the butterfly fragment, you want to be careful, otherwise you can separate that fragment and can have issues. So this is a 6-month follow-up. The patient did well. I'll show you another situation where you can see an 8-year-old who tripped and fell while walking his dog. Now, this is a difficult case in that you can see that there is a combination. There is a fragment on the medial side. The lateral side butterfly fragment. But more important, you see that there is a fracture line going across here. I don't know if you can see my arrow, but there's a fracture line going right here. And I'll stop, when there is, then their teaching point, but this is extreme, struggle getting the fracture. One is that you're so close to the fracture site when you're passing the nail from here. Okay, so we are starting to put the nail, and let's see what happens. Okay, so one thing you may notice is that when the nail is being passed, there is another butterfly fragment that is created, okay, which makes it really unstable. Now you have 2 butterfly fragments. Sorry about this. And then we also got a 3rd fragment where the entry site was. So I'll show you if this video plays, but it became an extremely unstable. We had to change the way we were nailing. So instead of going retrograde, we came from the greater trochanter. We were able.
Sheetal, we are seeing your first slide. So you'll have to unshare and start sharing again.
Oh, you are seeing the first slide.
So yeah. Now. So we saw part of the video, then it went to the first slide. So you'll have to unshare and then start and share again and go to the slide you were discussing. Yes, this is fine. Yes.
So it's showing that I need to restart. Okay, let me just close this and come back.
Yes.
Maybe I pressed things too quickly. So the point that I was.
So one question till the time, no? Of course, this comes back. Yeah, one question I had was there are instances when you have a butterfly, and then butterfly sort of jams the canal and does not allow your nail to pass through. So in that condition, how do you manage? So these butterfly, if it rotates and goes into the canal intramedullary.
Are you asking me for a butterfly?
Yeah, butterfly. Yeah. So it gets impacted, and that prevents passage of the nail. And if with traction or other maneuvers, you're not able to relocate that butterfly. Then how would you manage such a situation?
If you cannot, do the butterfly fragment, with the nail, then the other option is to do limited open management of the nail. The other thing is try to put the nail that is away from the butterfly fragment. So that is what I was trying to show, was how to try and see if we can manage the nail in this situation. And kind of just sorry that I can't. Okay, let me just share the screen. Okay, can you see it now?
Yes, it's come up. Yeah, 8-year-old
Okay.
tripped and fell. Yeah, we can see that.
Okay. So so here is the video of that. Okay, so what we are trying to do is go with the nail from below, but we are very close to the fracture site. Right now, you only see one butterfly fragment, but you see on the top, we'll create another butterfly. You can see the top butterfly fragment. So you have two fragments now. It's extremely difficult to manipulate these fragments. You can see the struggle. And in the meantime, we have created a third butterfly fragment where we started the nail. You can see that the nail, you see that there is a fracture right there where we started. And so now you have an extremely unstable situation. You have, so we come from the top, because from the bottom it's difficult to treat it. And we're trying to navigate the nail through the fracture site, coming in an antegrade fashion. So now you can see that one nail has passed, and this is the second nail. We are going to take an entry and put a second nail from the top. And you want to try and see if you can avoid all these fragments, the butterfly fragments, and still try to get the nail across. And it's been difficult trying to pass the second nail, because the fracture now is across such a long length. And so we said, okay, if we open it, we'll have to open the whole femur now, because the plate has to at least bypass the fracture. And so we start again with the bottom nails. Now 3 nails, trying to manage which nail would go through. And you can see that there are a nail coming from the top, from the bottom, trying to navigate through the fracture site. And ultimately, we were able to pass the nail from the top. So both nails are coming from the top. One is in a C-shaped position, the lateral nail. The medial nail is then rotated 180 degrees to make it in an S-shaped curvature. But you could see the struggle that we had. We had to change the plan from going in a retrograde fashion with both nails to come and then coming from the top. And we created a couple of butterfly fragments. Now, those fragments are usually there. That means they are undisplaced fracture lines. You may not be able to appreciate it. So you have to be careful passing the nail that you don't. This is where a stainless steel nail would create more combination than a titanium nail, because titanium is more elastic. So you need less force to put a titanium nail compared to a stainless steel nail. This is the ultimate result of that patient 1 year post-op. You can see there is no issues. The patient went on to heal okay. But you could see the struggle at the time of doing it. And when you have so much combination, as I was mentioning, if you try to plate it, you'll just have to put a plate all the way from top to the bottom. It was almost involving 2/3 of the femur at one point. So this is just about the technique, how we can manage the femur fractures, and then I'll go into complications. There are full videos. We have.
Sheetal,
yeah, go ahead. Now, I was just mentioning, if you have access to ViewMedi, then there are videos about entry sites for flexible nailing and femur elastic nailing that we have. It's been there for a while when we first recorded the nailing for a symposium. So it's you can access those full videos.
So 2 questions from audience on this. So excellent, demonstration of the techniques, and in difficult situations, how do we manage? So one question is, in comminuted situation or with so many butterfly, sometimes there is a shortening at fracture and there is a protrusion of the nails or back out of the nails. So how do you, prevent it? And then if it occurs, how do you manage it? That's one question. And second question is about possibility of using a submuscular plate in such situations, with or without nails. So, we want to answer sort of comments on both the questions.
So, the submuscular plate is obviously an option. The thing is whether you make a commitment.
You are not audible, sir.
Am I not audible? Can you not hear me?
Okay. Now it's okay, sir.
Okay. So for a communicated, I mean, for the submuscular bleeding, there are two ways you can do it. One is that you don't even try a nail. If you think that the fracture is comminuted, it would be difficult to put the nail across, and you can just go ahead with the submuscular plate. The second is making changes intra-op. So once you have trouble with the nail, whether you want to try and put the nail from an antegrade fashion or whether you want to change to a submuscular plate, that's something that you have to kind of draw a line that you're going to struggle for half an hour, maybe 45 minutes, and if you can't get it across, then at some point you would change to a plate if needed. So in this patient, we tried from bottom, then we tried from top. Once we got one nail across, then then you think that, oh, one nail is already through, the other nail should follow the same nail, and so we should be able to get both the nails, and that is the thinking, though it was a struggle even to get the second nail. So at some point, depending on your threshold on experience, you probably might be better off changing to a plate. The thing is that if you have planned for a nail, you need to have plate with you. That is your pre-op planning. You need to have something to back you up in case you end up with, like, in the last case I showed you, it was only one butterfly fragment that we could appreciate, but ended up having 3 butterfly fragments at the end. So some of those things were iatrogenic, and in our institution, it's not a problem because we have everything available. But if you're in a smaller setup or in a private hospital, you need to make sure that you have backup plans for these fractures. Especially the ones with butterfly fragments and spiral configuration. You can have, a combination intra-op, so you need to just be aware of it. Simple transfers and less oblique fractures would not be an issue. It would be easy. But for other fractures, either you just go straight to the plate, or if you're going to do nails, you need to have plate as a backup. The other thing is length unstable fractures, or one with combination where it collapses and the fracture may back out. There are strategies that you can use. One is that you can immobilize this patient post-op. You can put a spike on top of nail if you're really concerned that it's unstable. The second thing is a close follow-up. I'll share a couple of cases with you in the complications section and how to overcome a shortening. We have had sometimes go back in, either to push the nail back or to exchange it for a smaller nail. So yes, complications are there when you have comminuted and length unstable fractures. You just need to be a little bit careful about it. We still would prefer, our first choice is to nail it, and only in other circumstances, we would plate if it's an open fracture or we are going to open it to break the callus for a delayed presentation, then yes, it makes sense to plate those fractures. Should I move on with the second talk?
Yes, sir.
Yeah, Sheetal, please share your screen. Let's start with the complications now.
Can you see my screen and hear me okay?
Yes, sir.
Yeah, yes, perfect.
Okay, so we're going to talk about the complications. We just saw some of the technical sides of elastic nails. Just a brief, the first flexible nail that was introduced was from Steyr in Austria. That was the Anders nail. Look at this. This was in 1970 when Ender first introduced the nail. But then, there were issues with the Anders nail, and that is the principle was stacking of the canal. The second thing is that the tip was very prominent. There were issues with that philosophy. And so then Nancy nail is because of Nancy, which is the region in northern France. That's where Matatou introduced the elastic nails. This is his book on elastic nail. You can see the first X-ray in 1979 was based on the same principle as Anders nail. There was stacking of the canal using 3 or 4 nails, and it wasn't a balanced nail like what we see now. And Pierre Lescombs, he translated the manual into English so that it had wider acceptance after that. And this is a book which is called the Nancy University Manual. And it's, some of those things, we don't use it in practice. I just think that it goes beyond what we normally would use for normal fractures. For example, there's a chapter on how to do elastic nailing for supracondylar humerus fractures, where we know pinning works really good. But, because they are the inventors of the elastic nails, it goes everywhere. It goes into metacarpals, phalangeal fractures. everywhere it's elastic nailing. And then in the US, it was introduced by Dr. Wilkins, McEwen, and then the first trial that was in the US was in 1997, where it was a limited release of 58 patients. Had excellent results, and then it was accepted. We look at the complications. My mentor used to say that if you haven't seen a complication, you haven't done enough. And that is true that complications are underreported in orthopedic literature. So you need to be aware of complications. It's better to share them so we can all learn from those complications. We looked at more than 500 patients with elastic nailing, and you can see there were more than 200 in femur, and we published our complications. And you can go through the manuscript. There are a lot of complications that we saw, and then we have learned a lot how to try and avoid it. So the 10 mistakes to avoid. One is the fracture selection. Here is a 12-year-old male, weighs 35 pounds. So weight-wise, he's okay, a little bit older, but you can see it's a length unstable fracture. There is combination. I showed you a couple of examples, but here we went ahead and did the elastic nailing. It looked okay, but the same problem that we were mentioning when the patient came back 3 weeks later, there was shortening of 4 centimeters with nail protrusion. Now, this is not acceptable. Up to 2 is fine, but 4 centimeter shortening is too much. So what are the options? You can take the patient back to the OR. You can put smaller nails across. You still have to bring the length back. And then here is a submuscular plate on top of the elastic nail. We took him back and just maintained the length using just 2 screws above and 2 screws below. So it wasn't like the plate was big, but the incisions were just 2 incisions just to maintain the length till the fracture is glued. And then you can also use an IFICS. This is where an IFICS might be useful. We don't usually use IFICS for femur because of the refracture rates and pin track infections. But if you're going to use it for 3 or 4 weeks till the fracture is glued, then this is a good indication to, if you're going to put a nail and then you think it's really unstable and it's collapsing, you can put an IFICS on top. You can also stack the nails, but that defeats the purpose. If you put a 3rd and a 4th nail, like seen here, that defeats the purpose of balance nailing, which is 2 nails giving stability in opposite direction. There are end caps which you can place. I have not used the end caps. My concern with the end caps is that if the fracture is going to collapse and the nail doesn't back out, then where is the nail going to go? It's going to go approximately into the femur, either in the head or the neck. I'm more concerned about that rather than the nail backing out from the knee joint where I can manage it. So I don't like to prefer the end caps, but they are being used. You just have to, screw them at the end of the nail tip. You can get some irritation, staph infection, osteomyelitis stiffness, and joint swelling from the nail backing out. So that's an issue. The ideal indications are length-stable fractures, diaphyseal fractures, age less than 11 and weight less than 50. But it's not true for even not just tibia, even the femur nails. We have not found that the differences in outcomes is based on age or weight. We have seen that even in older patients, they're lightweight, or younger patients who are heavier, they do well with elastic nailing as well. One of our colleagues, and the group published this article where they had elastic nailing and then put an IFICS or a bridge plate and compared it. And you can see that this is elastic nail and a IFICS on top of it. And they had either the IFICS or the bridge plate. And what they found was that there were 19 patients in each group, and the functional and the radiographic outcomes were similar. The removal of the plate took more time and extended incision, and there was some pin track infection, 2 nail prominence in the IFICS group, and the bridge plate had 2 deep infections. Both were acceptable treatment. And as I mentioned before, it depends on your experience and resources, but elastic nail versus plate, both are acceptable. If you look at why there is loss of reduction, and you look at the articles, and the risk factors for loss of reduction or for malunion are fractures which are not in the mid shaft. So if they are subtrochanteric fractures, supracondylar fractures of the distal femur, or if they have significant combination, if you have mismatched nails and multiple injuries, those are the risk factors for you to lose the reduction. We looked at our pediatric subtroch and supracondylar femur fractures with elastic nailing. For the subthroat fractures, we had 36 subthroat fractures that we treated with elastic nailing. We had 4 head-to-head reposition or removal of the nails, 2 malunion, 1 iatrogenic fracture, 1 nail irritation, 1 limb length discrepancy. So pretty high complication rate, like 22%. We still do it. We have improved. We have modified some of the techniques. The 8 supracondylar fractures had 2 nail site irritation, 1 infection after nail removal. But I think some of these complications are preventable complications, but they do have a higher rate of complication compared to your diaphyseal fractures. So for a supracondylar fracture just above the distal femoral physis, you can see that we have used antegrade nailing, and it's a pretty acceptable reduction. You can, of course, use a plate here. That's a perfect indication. If you have metaphyseal fracture, you use a plate, or even if it's a little bit lower, to use cross K wires would be adequate. But you're just showing you some of the extended indications of nailing. Technique is equally important. See, ideal nailing, if you look at the femur on the left side, the nails cross at 2 sides, have a good spread at the fracture side. That's ideal. But when you see that the fracture starts to corkscrew, or when there is more than 2 points where the nails are crossing each other, here you can see the nail is crossing at 4 points, and that means that you are screwing one nail around the other nail, and none of the nails are then going to be efficient to control the fracture line. There is distraction, and there is mismatched nails. One nail is bigger than the other nail, which is an issue. Both nails have to be the same size. Each nail should be 40%, and I'll show a case. Just to illustrate, this is a forearm case. I just wanted to show it that this has a very narrow canal. The same thing happens when you have a fracture that's healing, that you would have callus in the intermalleolar area. It might be difficult to pass the nail. So, if you're struggling, here is a very narrow canal, 1.8 millimeters, and there is distraction of the physis as seen here. I've seen a couple of other cases being presented, similar cases. This is not common. I think that there might be some disease that we did not recognize, and the physis may be diseased. But just to show that, pushing it hard with the mallet, or trying to force the nail in is not an ideal way. So if the nail is incarcerated, that means you can't move the nail. You wait a little bit for stress relaxation. You withdraw, you rotate, and then you can reinsert, or you decrease the nail size if you can't pass the nail because it's getting jammed in the canal. And sometimes you can just use a short nail. You don't have to put it all the way across. You can just cut the nail if you're having trouble with the size of the canal after you pass the fracture site. There is a new design of the nail. This was introduced by Matazo's son. This was, instead of the nails being round, they are like semicircular, and they found that there is greater stiffness, reduces the risk of malalignment, and decreased radiation and operative time, because you would know the position of the nail based on where the flat end is, and it's easy to grasp it compared to a circular nail, and they have acceptable results. The material is important. We briefly went through it, but what happens with the titanium nail is that when you push the titanium nail, you can have a bend, or it would bend on you, because it's more elastic than the stainless steel nail. So sometimes if you're struggling and you're not able to pass the nail because the nail is bending at the insertion site, then a stainless steel nail would be better. If you look at the elastic modulus of titanium, is half that of stainless steel, and the bending stiffness of stainless steel nail is equivalent to a titanium nail, which is half a millimeter, I would say half a centimeter larger, 0.5 millimeters larger, sorry. So what that means is that the titanium nail is more elastic. So you would be able to you'll be able to insert it a little bit easier. The stainless steel nail would need a little bit more hammering, or a little bit more impact. And for the same reason, a stainless steel nail can cause more iatrogenic combination compared to a titanium nail. When you look at the complications of titanium and stainless steel, The malunion rate was 4 times higher with titanium nails compared to stainless steel in this study. And especially in adolescent and obese patients, we prefer stainless steel nails. But another systematic review did not show significant differences between them. 2 studies showed malunion was less in stainless steel, but 3 studies did not. And stainless steel is cheaper than titanium. So you can substitute titanium nail with a stainless steel nail as long as you understand that when you have a spiral fracture or a butterfly fragment, it's better to use titanium nails because you can have iatrogenic combination as seen here. This is stainless steel nail. If you do an open reduction, again, I'm going back to a forearm case, but if you do an open reduction, you need to follow those patients carefully. We hardly ever have to do it for the femur. When you drain the hematoma, then it leads to delayed healing. So this is a patient who had a non-union, had a fall, bend the nails. Your option is to take out the nails, put a plate across, but the other option is that you can do a close reduction with nails inside too. That means the nail, you can re-bend them in the opposite direction and put a cast on top. And there have been reports of successfully treating patients with bent nails without opening them. Here's an example where this fragment was poking out. So we opened it and passed the nail to reposition that fragment, but that led to a non-union, as you can see here. So anytime you open the fracture, just be careful. You follow those patients closely. Same with floating knees, you follow them closely. Here is an example, 11-year-old. You can see the femur fracture on the left and the tibia fracture on the right. What you don't see is if there is any physeal injury at the knee joint. Right now, we don't appreciate it, but we have 3 cases where we have had physeal issues. So maybe that you have to consider these fractures as a continuum of energy. That means that you have a tibia fracture and a femur fracture, everything in between may be injured as well. So this it shows an example of a good femur nail. The tibia also healed very well, but then the patient had a valgus deformity as well as shortening. So we looked at it closely and removed the nails, and what we found is that there was a bridge here on the lateral side of the distal femur. And don't know in hindsight whether it's because of the nailing technique, because of injury at the time of the trauma, or injury at the time of removal of the nail. Each one of them is possible, but in the end, we ended up, excising the bar and then, doing hemiepiphysiodesis for this. And he went on to do fine. This is his follow-up. He had a limb length discrepancy where he had you had 2 fractures and then he has overgrowth. And so we had to first correct this patient. We had to first correct the deformity, and then we did a epiphysiodesis to correct for the length. And at the end, you can see that his length as well as his alignment looks pretty good. But this is only possible if you have close follow-up on these fractures. Iatrogenic fracture can happen at the area of insertion, as you can see that. Here you can see another entry site fracture. I already showed you the entry site fracture in the previous case of femur nailing. So you got to be careful when you're putting your entry. It's better to be a little bit distal towards the metaphysis and not towards the diaphysis when you're taking your entry point. Here is another example of the iatrogenic combination that I showed you before. And then this was extremely unstable. Here is a case where then we had to change to a traditional plate. So I was talking to you about change of plan intra-op. So this patient, one is that the fracture was very distal, so not an ideal case for nailing. You could have plated right away, but we thought we'd be able to get it with nails. So we inserted one nail in a retrograde fashion, the other nail is coming antegrade. It creates more combination of the fracture. So now you have significant instability to the fracture site, and we thought, it would be very difficult to control it. So we have an intra-op change in plan. And so we went and opened it. We did, this is the interfract screw. This is traditional plating. So interfract screw, neutralization plate, everything went on to heal okay, but not ideal in the sense that we started with nailing, ended up with open plating after the first hour and a half in surgery. So you need to be prepared, is what I would say. Other thing is you want to check in both views. So here everything looks okay, but if you look at an orthogonal view, it's missing the distal fragment altogether. You want to make sure that you get orthogonal fluoroscopy even at the end of the case. You can see here that this was post-op recognized that the nail was out and was irritating the sciatic nerve here. Nail prominence is an issue. And so there are ways to prevent this. One of the ways is to avoid bending the nails at 90 degrees at the end and trying to leave them flush with the metaphysis. You can see here, this was done at some other place, and the patient then saw me in the clinic with this. We ended up removing the nail, but you can get skin slough infection. And if it's going into the joint, then of course, joint swelling. And this is one of the commonest complications, up to 50% reported reoperation for just nail site irritation. So we just tell the patient we're going to remove the nails. We remove the nails at around 6 months in all patients, but sometimes we have to go early. Sometimes we have to go early to remove the nails if there is a prominence of the nail. All right. So so the initial recommendation of nailing was to bend the nail 90 degrees when you were putting the nail, like you can see on the right side. But the modification is to not bend the nails 90 degrees to prevent that prominence, but instead we need to leave them flush with the metaphysis. The long nail is also an issue. Dr. Gupta, can you mute your phone in your Zoom, please? Too much of distraction. Hey, Ashok, can you mute him?
Contact Ashok, I think. Yeah, I've already.
Okay, so long nail is also an issue. You can see this example. This is a 14-year-old boy with a gunshot wound to the left thigh. This was my case from last year. He had an open fracture. And I'll show you the video of this. So we decided to do antegrade nailing in this patient because the fracture was a little bit distal. So you can see the starting of the nail here. We went ahead and put our first nail through. This is a fracture reduction device, and then a little bit of manipulation. And then we are able to get it through. And then we have taken the entry for a second nail. And then we were able to pass a second nail. So everything looks good. The reduction and the positioning of the nails, everything is acceptable. My only point here is that the last shot that you take should not be of the fracture side, but should be where the nail is ending. What frequently happens here is that once we see this X-ray and we think everything is good, then you cut the nail and then you further impact the nail. And what can happen, two things can happen. Either it can distract the fracture or the nail can be too long. That means that the nail can then penetrate distally. So you want to make sure that that does not happen, because it's typically at the end of the case. When you're done with nailing, you just have to impact it after you cut the nail. So you want to make sure that you check your shot. So here is this patient, and everything looks good as far as his alignment and the nail is concerned. But if you look at the distal point of the nail here, this is 6 months post-op. The fracture has healed, and the patient comes back because he has pain in his knee. And so I took him back. I opened the knee just a little bit, and you can see that the nail is protruding just above the trochlea. And that's because we did not take an X-ray at the end, at the end of the case. I'll show you another example of this. In this fracture, 12-year-old boy, forearm injury, and this is the last fluoro shot I had. Okay, so you can see that the nail insertion point is okay. But what happened after this is that the nail was further impacted after the nail was cut, and we didn't have a fluoro shot after that. So when the patient comes in for 3 weeks follow-up, you see where the nail is. And it's not because the fracture site has collapsed. If you look at the intra-op fluoro shot and you look at the post-op image, the fracture looks exactly the same. It's not impacted anymore. It's just that the nail was impacted. Once the nail was cut, it was impacted and did not realize that it was impacted too far into the joint. Now, luckily, what happened is that 2 days after this, so we spoke with the patient, we said we might have to remove the nail early, or we might have to go in and reposition it now. And what happened is 2 days later, the patient was trying to catch a football and had this injury to his finger, which required pinning. It was on the same side. So I spoke with my partner who did his surgery, and when they were pinning it, they pulled the nail back. So he did not require a separate OR procedure because he was going to the OR anyways. He just pulled the nail back at the time of his surgery. But the point is that you don't want to leave the nails long going into the joint. And I've shown you 2 cases of that, and this is the same patient 2 months later, everything healed fine. But that would require returning back to the OR if the nails are left too long. So you need to make sure that after you impact or after you final, when you're ready to close, that is when you want to take a last fluoro shot, because it's easy for you to put it back and trim a little bit more rather than going back to the OR later. As far as nail removal, you can retain the nails if you have used it for pathologic fractures. Here's a case of a patient who had a forearm fracture, and the patient did not show up, and fracture went on to heal, but the nail was kind of way in the canal and difficult to remove this nail. And 4 years later, he had another injury. And this was undisplaced injury, so it was treated, with a cast and went on to heal. But you can imagine that if you had a fracture and then you had to remove this nail, it would have been extremely difficult to remove the nail. And then how do you manage a fracture if it's within the area where the nail is? Whether you have to plate it or you have to put another nail through, it's going to be difficult. So it's better to remove the nails, roughly around 6 months after the surgery. We tell all patients to take the nail, to remove the nails. Here is a 9-year-old boy who is 2 years post-op. I showed you this X-ray, and then we went ahead and removed the nail. If you can't get the nail easily out, the tip is to use the suction tip, put it on top of the nail, then you can bend it at around 90 degrees, and then you can remove it. So I would just stop here. We looked at the technique as well as the complications. Attention to details is important and can happen to anyone. Just you recognize it, treat it, and learn from it.
Well, thanks. A lot of important practical points for all of us who want to use elastic nail for stabilizing femur fractures and other long bone fractures. And what I learned is, in spite of your best intention in a difficult case, complications can occur, and you should be ready with an alternative fixation on table. Otherwise, it can be difficult. And any comments from Sandeep or Premal about complications, and which are the cases the chance of complications would be more? And from audience also, if there are any quick questions, put it on the chat box or unmute yourself and ask.
Well, it may be a good idea just to discuss something about open fractures. As we did little before a few people joined, but I think now since we have almost full house, few tips on open femur. I think that's what was mentioned in the group organization. Sheetal,
so femur fracture, yeah, Sheetal, how do you manage open fracture?
So femur open fractures, as per the latest definition, they always consider to be grade 3. That means that even if you have a small poke hole, the amount of soft tissue trauma it takes to get a femur fracture to be open is significant, and that means that you treat all femur fractures as open grade type 3. That means right from the timing of your antibiotics to treatment, whether you need to do a debridement or whether you need to admit the patient and admit for observation for compartment syndrome, for neurovascular injuries, as well as for any antibiotics. So you have to treat all open femur fractures as a type 3 or that is Gastilo type 3 and follow those principles. As far as fixation, it's not a contraindication even in bad injuries with soft tissue, injuries or even a little bit of soft tissue loss to nail it. That means that even if you're it's not that you have to plate these fractures. We end up nailing these fractures. Probably using more rigid fixation is better from trying to prevent further injuries. So, using a rigid nail for a lot of these adolescent patients in open fractures is a good idea instead of the flexible nails, since they have more stability. And if it's really bad, then you can use an X-Fix, but we hardly ever have to use an X-Fix. I don't remember the last time we put an X-Fix on as a primary treatment. So those are the typical tips I have. Femur fracture, when they're open, there is significant injury. You need to make sure that you manage the patient as a whole.
Sandeep, what has been
whether you see gunshot wounds, but no, gunshot wounds are treated as closed injuries. That means you don't need to do thorough debridement. You don't need to open and treat it as if it's an open fracture. For our setup here, gunshot wounds are treated as if they are closed injuries.
Sushant, you had a question. You raised.
Yes, sir. So yes, sir. So I had one doubt, sir. Even after doing a tense nail fixation, should we give the patient a slab, a posterior slab, or we should just we should not bother doing that?
It depends on your fracture configuration and the stability you get. I don't think I showed you a normal case. All those cases that I showed you were, long oblique, unstable fractures. But most of the fractures in practice are either, transverse or short oblique. Now, those fractures are not, this much of an issue. You put the nails, you can, if the patient you think is kind of a little bit, compliant, or if you think that the fracture is pretty stable, I just use an immobilizer. I don't put a cast on. But, if you have a length unstable fracture where you want to maintain, either the length or the reduction, and you're using a cast for that purpose, that's another issue. But for a stable fracture, using an immobilizer, which is a brace, and that too, just to make sure they don't bend their knee too much, to give them comfort, let things heal for the first 2 weeks is what I've used for stable fractures, and a cast for unstable fractures.
Thank you, sir.
And a cast is not a hip spica cast. Okay, it's just a long leg cast, just to give some support.
Okay, thank you.
Sir, in a compound injury, compound fracture of the femur, how many days you'll give antibiotics after the debridement?
I would usually do because the patient is admitted, I would do my usual antibiotics is for a week, but the IV medications is usually just for the first 24 to 48 hours. Then we switch to oral, unless it's really contaminated fracture where you're using 3 antibiotics. You might want to prolong it, but usually 24 hours of IV antibiotics followed by a week of week-long oral antibiotics is what I've used. Now, for a grade 1, which I said that you treat all of them as grade 3, but from an antibiotic standpoint, grade 1, we just give it for the first 24 hours.
Antibiotic prophylaxis for the diaphysis and metaphysis is the same, or will you be aggressive in metaphysis compound injury at the metaphysis, sir?
No, I only know a few antibiotics. If I have any doubts, if I have concerns, I will just have the infectious disease guys control it. But for typical open fractures, I just use an NSAF, that is a cephalosporin, and then add an aminoglycoside or penicillin if it's more contamination. But I don't change it based on the location of the fracture. Now it's another thing if it's if it's infected, that's another thing. But for prophylaxis, just use a single antibiotic.
So, any other questions? Otherwise, I'll ask Sandeep to start off his talk on adolescent fractures. So we started almost 9:45. We'll listen to Sandeep, and there is a suggestion from Premal that if everyone is okay, his session on case discussion with more added cases from our side will do as a next session. And we can also invite some of the cases from the delegates. So we can do case discussion as a separate session. But Sandeep, you can do your talk now on adolescent fracture. Please share your screen.
Hello, can you hear me?
Yes, Sandeep, very, very faintly.
Hello, can you hear me? Hello.
Sir, less voice, sir. Low voice, sir.
Can you hear me?
Low voice, sir.
So
very faint,
we can
sir,
hear
very
you,
faint.
but the voice is very
Sandeep,
faint.
your voice is
very
low.
faintly.
Yeah.
Very faint, sir. Maybe net signal.
Hello, can you hear me?
Yes, sir, we can hear you, but the voice is very faint.
Sandeep, in your audio section, increase your output mic level high. Next button, there is an arrow in that.
Where?
Near that mute arrow, if you are on a laptop or on computer, mute. Near the mute, there is an arrow that will open the sound settings. Increase your mic volume level, input mic volume level.
That is full.
Your sound is fine now, Sandeep. Yeah,
Can
share your screen.
Can you hear me now?
Better, much better.
Yes,
Okay.
sir. Yes, sir.
Okay. So we've had a really exhaustive session. Sheetal has been brilliant as usual. I think we will just rush through a few adolescent cases to highlight a little few differences that we see in the age group that we are talking about. And most of the things have already been covered, so I will not really waste too much time. This was a 15-year-old girl who was weighing 60 kilograms, and she had this middle third shaft femur fracture. And as usual, we thought that this is an ideal case. It's a middle third ischemic diaphyseal fracture, and we should use elastic nails. And we did use elastic nails, and we saw that there was callus, but because you see that there is a long lever arm and the heaviness of the patient, when she started knee bending, slowly she started developing a procurvatum deformity. The callus wasn't maturing fast enough, and she ended up with a deformity of procurvatum and a thigh which was palpable anteriorly. And at that age, it was difficult for this deformity to remodel. So basically, in adolescent age group and heavier children, what happens is that the elastic nailing system may not be strong enough to sustain the bending forces, and there is very little time remaining for the body to remodel it. So the primary fixation which you do or offer must give absolute stability or better rigidity to prevent the bending forces, and which is why what is now available is the adolescent nailing system. The second situation, where in adolescent you have a floating knee situation, where you have an older child with a fractured shaft femur and a fracture of the tibia. Now, in this situation, an elastic nailing was done and tibia elastic nailing was done and femur regular interlock nailing was done. Now, this healed satisfactorily. This was done by my adult colleagues, and this is what they follow. But if you see the entry point of this nail, The error is that they tried to do the nailing with the adult entry point through the piriform fossa. Now that is a very dangerous situation because the lateral epiphyseal ascending artery is passing from there, and there are all the reported AVN cases post nailing us because of entry point through the piriform fossa. So what is reported in literature and what is recommended is that do not use a piriform fossa entry. Rather, we should use the lateral entry through the tip of the trochanter and use titanium anatomically contoured nail. So here is an example of a 16-year-old boy who had a transverse shaft femur, again on the heavier side, 50 kg and plus. And this is the typical adolescent nail. I have used adolescent nail in these indications where you have to make a trochanteric entry from the lateral. The nail is bent so that it accommodates the canal through a lateral entry, and it has got a anterior bow. It's got a procurvatum bow. So there is a right-sided nail and a left-sided nail, and it comes in diameters of 8, 8.5 and 9 millimeters so that you can use it in children. And it has locking options, either transverse going into the neck or inferiorly, and you have locking bolts. So a solid titanium nail will offer a better bending stress resistance rather than just the elastic nailing system. And this is how the fracture healed in about 12 weeks time and consolidated in 3 months time. So this will give you a far superior result in the adolescent age group rather than doing titanium elastic nailing. So heavy patient, adolescent patient, or then comminuted unstable length, unstable fracture situations. And junctional fractures like this. Again, an older child with a transverse subtrochanteric fracture, which was treated with a adolescent titanium nailing with a proximal to distal intertrochanteric locking bolt and a couple of locking bolts distally, and you can see the excellent alignment, and that was the result in 3 months time where it healed uneventfully, and we could mobilize the child very early on walker and was weight bearing in about 6 weeks time. So when you have the comminuted fracture shaft of the femur, and if you do not have the elastic nailing system, again you are in a dilemma, as Sheetal pointed out, that you must have a backup plan. Now, if you see this comminuted fracture shaft femur, the problems are this is length unstable, the child is older and is heavy, and the fracture is comminuted to that extent that it is going right towards the physis. There's a third fragment which is very large. There's a spiral which is going right to the supracondylar to the physeal region. So this is eminently unstable as well as unsuitable for giving a hip spica because the child is 13 or 14 years old. Plating will involve a large exposure and the plate might go across the physis. Elastic nailing is like a contraindication here. So what are the options for treating this fracture? So with this particular dilemma, what I decided was the best implant for me, which will still keep the fracture closed, align it, restore length, and give adequate stability would be an external fixator. So I just used a closed external fixator, couple of pins in the proximal and the distal segments without transgressing the physis, and we maintained that for 12 weeks. Because it was a closed injury over a period of time, this consolidated very well, the fracture healed nicely, and we protected that with a thigh brace, and that went on to absolutely solid union with absolutely normal function. But because it was a long segment unstable fracture and the child was older, the healing time was much prolonged. And as you know, there can be delayed healing with external fixator and also the chance of refracture. We were very wary in very early or rapid mobilization for him. But in certain unusual situations, such as this one, an external fixator can be an useful substitute to doing a plaster or a compromised internal fixation with an implant which is suboptimal. So this can be a very good standby option. Now, this option has already been discussed, a severely comminuted adolescent femur fracture. Now, in this situation, it was proximal 1/3 away from the distal entry point of the femur, and I could pass elastic nails. And in addition, I supported it with a fixator for the length stability and bending stability. So, with those comminuted pieces restored or pulled out to length, the entire procedure is a closed procedure. You do closed elastic nailing, which is like an aligner, and then you use an external fixator to stabilize. As callus forms, you can remove the fixator and it will the elastic nail will give you internal stability, and you can protect the thigh with a corset and allow the child weight bearing. And in another 6 months, this eventually went on to healing with full range of motion. This is another example where you have a proximal third child, 11-year-old child with a proximal third comminuted femur. Now again, in this situation, you can do elastic nailing with an external fixator for length stability. But looking at the proximal nature in the subtrochanteric region, the surgeon thought that he was more conversant with plating, and this is what was offered. Now, the problem with this regular plating was that the proximal segment was inadequately stabilized. Though there were 2 interfragmentary screws, the plate itself, the span of the plate was very short, and the inevitable happened. It went on to an implant failure, and the plate bent and broke eventually. And then we had to revise it with a longer plate and local osteoperiosteal flaps, which was a locked plate, and that went on to satisfactory union. So what you have to realize is that in certain situations, plating is not a bad option, but the principles of plating, the span of the plate, the length of the plate, and the placement of screws is also very important. This was a non-union, hence so many screws have been used. In a primary sliding plate or a submuscular plate, you do not need to put so many screws. You can use distal screws and span the fracture in a sliding fashion without opening the fracture. But in a revision case or a non-union, you need rigid fixation with local bone graft stabilization, and that healed in 3 months. Now, this was another unusual situation where a patient which I inherited, a 12-year-old, again, probably the surgeon did not have adequate implants. He nailed one side with Ender's nails, and on the opposite side, he put a plate. And the child came to me unable to walk with synovitis on the right knee and a deformed left knee, which was not healing. So those were the problems. So in this situation, I could see that there was some attempt at callus because the right was a closed procedure, the nailing part, and the femoral plating was an open procedure, which was proceeding to non-union. So what we did was I cut the nails which were irritating the synovium, and we used an LRS here. With the LRS, after we removed the plate, we just used an LRS to distract because it had collapsed and the length was also an issue. And then I could make the child weight bear early with the LRS and on the opposite nail. And with this kind of a fixation or a jugaad, as you might call it, this was the result in 3 months, and we could remove both the implants. And this child recently came with a longer follow-up with both the femurs healed very nicely and remodeled very well. And finally, when you have a junctional fracture, like a comminuted supracondylar fracture, supracondylar premal bias already discussed, you can do a percutaneous intra-articular fixation and couple of AVALs, and that can also heal in adolescent age group with casting techniques. And facial injuries, again, in heavy kids, if you are going to do fixation, you need to have a metaphyseal screw, and across the IFICS you can put a couple of pins, but you need to protect them with a cast and they can heal satisfactorily. So with those couple of cases, I think I will stop. Thank you, Taral. Taral, are you there? If there are any questions regarding what we discussed, we'll be happy to answer.
Can you hear me, Sandeep?
Yeah. Sheetal, I'm here.
So I had a question, about do you routinely remove the elastic nails or the rigid nails, and at what time frame would you remove them?
Yeah, so the elastic nails, I remove them after 9 months in the femur. Usually it comes to me naturally from vacation to vacation. So in India, we have two major vacations, Diwali and the summer vacation. So typically what happens is that the next upcoming long vacation is the time where we do all hardware removals. Most parents want their implant removed, and we try to remove them after I see good cortical union, more than 3 cortices, and adequate remodeling. And before the nail really migrates, in the sense the nail doesn't really migrate, but the IFICS grows away and your incision site changes. So I will remove them in the next big vacation. And the rigid nails, I will not insist on removal.
Yes. Thank you.
Yeah. So what I've been doing, Sheetal, is that, like you said, a temporary external fixator is usually my choice rather than in length unstable fractures for a short period till the soft callus forms, because I can pull them out to length and I can get them to move their knee rather than a cast. Incomminuted, of course, when there is an issue with instability purely by nails.
Yeah, no, I think that's a good option, either putting a plate across or IFICS. The only thing is that you make the decision during your first surgery, whether you want to supplement your elastic nail with IFICS and plate. Whereas we make the decision later on. So when we follow up, we tell them that if there is going to be an issue, then we would go back. So
yeah, what happens in India, people do not accept a second surgery.
Right, but the rate of us doing the second surgery is very low. I mean, or for all these length unstable fractures, it's possible. I have to go back and look. It's possible that we have some of these patients did go on to have some malunion, but I've not seen a length issue, with this comminuted fracture that they would collapse. But the ones that did, like in follow-up, I would say we have maybe 4 or 5 patients that had a second surgery to either put an IFICS or put a plate across. So it's not very common, even with this all extended indications. But we let the family know that, if at the first follow-up visit, which is usually in the first 2 weeks, if there is an issue, we might have to do something more. But you do it during your first surgery. So that's a decision that you take intra-op. Is it based on how you move the fracture after you finish your nailing, whether you see more movement?
Yes. So if I see segmental comminution in an older child with a heavier body weight, I will definitely use a fixator. I have had situations when I have had spiral or long obliques, which initially I thought are going to be unstable, but after a reduction, they were so stable that I have left with just, like you said, a long knee brace or a slab for 3 weeks, and they have done beautifully well. So what I do is, after I fix them, I do a push-pull, and I try to see whether this is going to slide. If it is stable, I don't touch them. So a younger child, a lighter child, and on-table quality of reduction, if it is good, I will not put the fixator. But segmental comminution, 10 plus 45 kgs and above, and when I'm pushing and pulling, it's creating some movement, then I will pull it out to length and put a fixator. The only issue I have had is in compound fractures, where we have had inside-out compound, like you said. I do elastic nailing with the fixator as a rule because they take a long time to throw callus. Whereas the closed fractures, I can predictably remove them at 4 to 6 weeks because I will always see callus. If I've lost the fracture hematoma, it takes a long time for callus to come.
That's a good point.
What is the cost of the special adolescent nail trochanter entry?
The cost is a concern. So this happens only for our private room patients because it costs 40,000 rupees. The Smith and Nephew adolescent nail, titanium. So in the heavier patients, we recommend that, and if they say no, then we have to fall back on other things like elastic nail with plaster or fixator or something like that. I am with Sheetal as far as being a nailer. I don't like to plate. I don't like to open the fracture. I will do elastic nail with a fixator, but I will try to keep it closed as far as possible.
Sandeep, both of you one question. I have done couple of times tibial interlock in femur, which is there are few nails which has got Harzov, which is much less, which is quite in tune with and higher, quite in tune with adolescent nails. The only thing is that locking is in a different direction. The proximal lock to anteroposterior. Except that they're quite a reasonable option at a very, very reasonable cost. I think 120th cost, I guess.
So people have also used humerus interlock nails, but again, like I said, the more you evolve in an urban setup where this kind of fixation, which is off-label, as they call it in US, in case of failure, will be questioned as a negligence because these nails were not designed to be done in the class of patients that we are using them for. But you have to adapt to the situation. If you feel that is going to work for you in your hand, I don't have an objection, but I would like to be as correct technically as possible. Sheetal?
I was gonna say that before the adolescent nails came, because they have only introduced adolescent nail lately. We used to use tibia nails all the time, and we have a publication on using tibia nails from our hospital, using it for the femur fractures. So if cost is an issue or if availability is an issue, then that is an option, to use the tibia nail for the femur. We have used it in the past, but now that we have all these different nails, the other thing is that you want to be, careful about the proximal shaft. I mean, the proximal diameter of the nail. All these nails, they may be 8 or 9 diameter in the shaft, but proximal reaming that is required may be 12 or 13. And so the other thing about the adolescent nail is that the proximal reaming is much smaller than an adult nail. So because in a kid, if you use it, you can blow the trochanter if you put a 13 millimeter reamer on to put an adult type nail. So the same thing with the tibial nail. So you have to be careful that what is the size of your proximal reaming to put the nail in. But tibia nail is an acceptable option if you don't have an adolescent femur nail.
Sandeep, going on the same line, in osteogenesis imperfecta patients who are closing to maturity and had a very old nails, I have frequently used humerus interlock, and they worked really well, because that is the only nail.
Yes, I agree. Totally agree. Pathological fractures and special situations demand special expertise as well as understanding of what you are trying to do. But my issue with the OGI patients has always been the canal diameter, which is so flattened bone, and that getting a humerus interlock, at least for this fellowship, I think I will not recommend. We should still go with the telescopic rods or the rush nail primarily, because you might shatter the entire bone if you're trying to use a humerus nail which has a different curve. Because the bone itself is bent in so many directions, you have to be really an expert to negotiate that kind of a rigid nail.
I think, Sandeep, you already answered this question about using cerclage with 10 nails. It's not a good idea.
Yeah, because there's no point opening it. No, why do you want to open? And then if you're opening, you might as well plate it.
And cerclage is strangulation of the bone. It completely
Yeah, you
cuts
are going to
across
murder the periosteum as well as. So not a very good idea to consider this at all.
And other ways to give stability. So one
Yes,
sort of point
yes.
I wanted to discuss was that submuscular plating. And though we had a publication, I want to say that reduction in submuscular plating is not easy, especially on a lateral view. So lateral view, to pass the plate and get the plate across and get a reduction. So you need to have additional, tools up your sleeve. And sometimes, in those cases, passing a nail, an elastic nail or a rush nail, just to get a reasonable alignment and then doing a submuscular plate makes it easy sometimes. And if you have a case discussion, I'll just show one of the cases where
I have a feeling that there is nothing more biological than doing a closed elastic nailing, and if you have rotational or length issues, adding a fixator is more biological than a submuscular plate, where you have issues with removing the implant later, as well as it's a hangover of the adult plating brain. That's it. You just want to get a plate there. That's all.
So Tarun, to your point, we have most of the bone-specific plates now. So we have a femur plate as well, a long femur plate going from all the way from trochanter to the distal femur. It's curved. It has built-in anterior bowing. So the procavatum is just the same plate on each side. You just have to invert it. So it may not be available everywhere, but it is going to come. Like, we have specific plates for each bone. The same way, if you put a straight plate onto the femur, and you don't take the bone into account, then yes, on a lateral view, you are going to have issues. But if we have to use it, we use one of those anterior femur plates. I mean the lateral femur plates, but they are bone specific. They have a curve that's built in. So just so you know that they are plates. It's an orthopedic plate that's available.
Right. So femur fractures in children, what we have discussed is you have to have all the sort of tricks ready with you. You should be able to give a good spiker. You should be able to nail well. If required, you should be able to plate well. So it tests your skills to maximum. And it's a very interesting fracture to treat all the time. So I think if there are no further question, or even if there are further questions, I'm going to end the session today. It's almost 10:12 in India. And for Sheetal, it's going to be afternoon soon. So we'll have another session, especially for cases, interesting cases, and Premal would lead that session. And if any of the delegates want to present an interesting femur case, you're most welcome to contact Premal or put it on the group and be ready with your PowerPoint for the next session. The whole question is, when should we have it? Sandeep and Sheetal and Premal, should we have it next weekend? Is it possible to have this session, or should we have it?
Yeah, I'm okay.
Next, same time next week. Sheetal, would you be available? Is it possible?
I may not be next week.
I would prefer a weekday, Taral, not a weekend.
No problem.
Yeah. Do Wednesday or Thursday?
Yeah, sure.
So let's put it on the group and then decide.
Get Sheetal's time.
Yeah, I will ask him. Yes.
All right. Okay, Taral. Good night.
So happy weekend to everybody. And
Thank you.
Thank you so much.
Bye. Thank you, sir. Good night.